You are here to join us to this session of the PPI seminar series. And today we are excited to have a talk about integrating structural and real-world data to advance cancer prevention research. This seminar is being hosted by the Persistent Poverty Initiative, which is a collaboration among the Acres Homes Cancer Prevention Collaboration, University of Texas, the Cancer Awareness Research Engagement and Support Center, UAB, the Center for Social Capital, Cornell, Columbia, and SUNY universities, Hope and Care Together, University of Utah and Montana State University, and the Upstream Research Center, Stanford, UC Davis, and UC San Francisco. Our speaker today is Dr. Elizabeth Baker. She's an associate professor in the Department of Anesthesiology and Preoperative Medicine and in the Division of Pulmonary Allergy Critical Care Medicine at UAB. She also serves as the co-director of the UAB Social Determinants of Health Institutional Research Core, which supports investigators across institutions in measuring and integrating social and structural factors in health research. Dr. Baker holds a PhD in sociology and demography from Penn State and completed a postdoctoral fellowship in the Labor and Population Division at the RAND Corporation. Her work uses large data sets, electronic medical records, and disease registries to examine how social and structural conditions shape longitudinal health outcomes, including pulmonary function, obesity, cancer, kidney disease, and mental health. She has published widely on these topics, and recently she has published on cystic fibrosis, COPD, geriatric oncology, and structural drivers of health disparities. She has mentored a huge number of trainees from high school to faculty. She loves teaching. And she will be talking to us today about real-world data and cancer outcomes. Please join me in welcoming Dr. Liz Baker.
Hello, thank you so much for that, Lucia. That was a great introduction. So what I'm going to talk to you today, the title of my presentation is From Census to Clinic, Integrating Structural Data into Real-World Health Research. And before I get into my talk, I want to acknowledge my collaborators and colleagues. Ariane Nassau is our amazing geographer and spatial analyst at the SDOH Core. And some of the graphics and maps I use here, she created, specifically the pretty ones. Admittedly, I made the ugly ones. Lucia Juarez, who you just heard from, she is our talented statistician/methodologist at the SDOH Core. Gabriella Oates is the director and is amazing and puts everything together into big picture ideas. And also Qasim Husseini, who is a HEMOC doctor here at UAB and also has an MPH and a strong interest in cancer and policy. And he is my collaborator for the real world example that I'll show you in this talk. So in this presentation, I'll go over census geography, some SDOH measures, social determinants of health, and how you can incorporate them into your research questions. And finally, I'm going to show you some preliminary results that I've been working on, integrating property records with cancer data. So one thing I love about census geography is that they are all perfectly nested within each other. So this graph demonstrates the hierarchy of census geographies. And what I want to draw your attention to is this middle section. The whole US is divided into states, states into counties, counties into tracts, and tracts into block groups, and finally block groups into census blocks. Census blocks represent the most granular measure, and oftentimes we think that more granularity means better representation of a person's neighborhood or community. But more granularity also means the estimates are based on fewer people, and when you have fewer people, this leads to less stable estimates. As such, the sweet spot for most SDOH research looking at the influence of area level measures tends to be at the census tract. Census tracts are the workhorse for population research. They are designed in theory to try and represent a neighborhood. They typically contain between 1,200 to 8,000 people, with 4,000 being ideal. They are intended to be relatively stable over time, which is why they're so valuable in longitudinal public health research. In Alabama, and because I am in Alabama, a lot of the examples I'm going to show you are in Alabama, we have just over 1,437 census tracts. We also sometimes use what's called a block group. These are smaller than a census tract, contain fewer people. They have around 600 to 3,000 people, and they represent sub-neighborhoods. And a lot of the measures that I'm going to show you are either measured at the census tract or the block group. The other form of geography that people tend to want to use in SDOH research are zip codes. These have some obvious positives. First, people understand what a zip code is. Census tract tends to require a little further explanation. Also, people tend to know what their zip code is. I know what my zip code is, but admittedly, I do not know what my census tract is. And while zip codes are appealing, I would strongly caution against using them. Zip codes are postal routes and were made to optimize mail delivery, not to necessarily represent neighborhoods. Additionally, they're not even polygons. Zip code boundaries and definitions can change at any time, and new ones can be introduced and old ones can be discontinued. Compared to census geography, where census tracts can change, but they only do so every 10 years with a decennial census. Also, zip codes can be non-contiguous, meaning the same zip code can be used in two different places, where census tracts are always contiguous and contained. And most importantly, information does not really even exist at the zip code level as an area. Rather, if information does exist at the zip code level, it is at the zip code tabulation area, which is defined by census. You can get census information at the ZICTA, zip code tabulation area, level. And ZICTAs are built by aggregating census blocks based on zip usage. Thus, ZICTA boundaries are essentially block group boundaries. But this can introduce spatial misalignment. So let me show you what this actually means in practice. So on the left, I have two zip codes with the ZICTA boundary imposed on top of it. And as you can see, there's some of the zip code 3508 that ends up in being in the 35207 ZICTA. This is what I mean by spatial misalignment. Also, I wanted to draw your attention to the figure on the right, which demonstrates which census tracts are in the zip code 35207. And the reason that I want to draw your attention to it is because it's particularly useful in the next slide when I suggest fixes if you only have zip codes. So what do you do if you only have zip codes? Well, not all is lost, and you have two decision points ahead of you. And which one you use is really up to you. The first thing you can do is convert the zip codes to ZICTAs, and HUD has a nice crosswalk to do this with. If you use the ZICTA, the nice thing about it is that it's based on real data with real boundaries. Similar to how we get information at the census tract, state, or county, now we just pull that information at the ZICTA. Though, as you saw from that last slide, there's still the opportunity for spatial misalignment in the sense that the people in your ZICTA might not live in your zip code. The second thing you can do is convert census tract to zip code weighted measures using a different HUD crosswalk. And in this crosswalk, what we have is the proportion of addresses from that zip code that are within that census tract for all census tracts that have that zip code. So what does that mean in practice? So why I thought this was useful. So 40% from census tract 1 for the zip code. So 40% of the addresses from the zip code come from this first census tract, 20% from the second census tract, 20% from the third, and 20% by the fourth. Then I take my census tract estimate from tract 1, times it by 0.4, the estimate from tract 2 times by 0.2, same thing for tracts 3 and 4. And then I aggregate it up across that entire zip code. And what this gives you is a census tract weighted zip code measure. A word of caution, just because I've done this several times. Remember how I said zip codes change all the time? The HUD crosswalk offers crosswalks for every year for every quarter. So for 1 year, there will be 4 different crosswalks that you can use. If you're using any of the area level measures that at least I've explored that you'll see here on this presentation, for some reason, the fourth quarter works the best. I've tried all of them across multiple different years. The fourth quarter is going to give you the best alignment. And so I personally, weirdly enough, kind of like the second way of doing it. It strangely removes geography from the equation anymore. It's just if the address is within that census, or if the address was within that zip code. I did both of these measures recently for a colleague. I gave them both ZICTA-derived measures as well as tract-weighted zip measures. I have not figured out what he has done with this, but I'm really hoping he'll come back to me and let me know what differences he saw and which ones performed better. As census geographies, they are designed for population analysis, but if you have zip codes are better than nothing. It's just important that you understand what this means for the interpretation of your findings. So now I'm going to go over some of the area level SDOH measures that you can use in your research. Also, and hopefully y'all don't hate me for this, critically examine the persistent poverty definition. So I just wanted to give you a quick overview of what the different measures are available for you to use in your research. And while this is an intense table, it is not the most intense table I will show you, just to warn you. It's also not meant to be an exhaustive list, but I do try really hard to stay abreast of what measures are out there. These come at different levels of geography, though most use the census tract, and they include different measures in them, though there are some measures that tend to be in nearly every single measure across these different indices. These measures include things like access to healthy food, exposure to environmental toxins such as pollution, risk of crime, walkability, and most include some aspect of socioeconomic status. Before I go over what actually is in any of these indices, I wanted to take a minute to discuss how these measures are actually derived. Several of the measures use factor analysis or principal component analysis to determine the scores, which capitalizes on what covariates together and not does it explain variance in the outcome. The other most common way the indices have of doing this is by standardizing and then ranking, which means that each one of the measures in the index is giving the same amount of weight. A moment about ranking. Most of these then also rank these census tracts. What does the ranking mean? The ranking means how deprived is that census tract compared to all other census tracts in the US or to that state. Oftentimes you can get ranking for the whole US or for a state specifically. So a value of 0.75 on the Environmental Justice Index means you are in the 75th percentile of deprivation. 25% of tracts are doing worse than that tract and 75% are doing better. Interestingly, the Child Opportunity Index does something a little different, and it weights its measures. The weights that it's used are derived by how well that measure predicts a downstream outcome. And there's 3 different downstream outcomes. One of them is living in a high poverty census tract at the age of 35. And like I said, this is now interesting is that it's weighted by how well it explains an outcome, but the extent that that outcome is relevant to your research could be kind of iffy. So it's important to understand what these measures actually mean. Concerning the rankings, I do want to point out that you can always re-rank your measures to your sample. So if you re-rank and have a value of 0.75, that would now mean that this is the 75th most deprived census tract in your sample, and not the 75th most deprived tract in the US or state. This can be really important to do if your sample is skewed more towards the well-off or deprived. It allows for more variation in your sample. and most research suggests that you should do this. And while I do generally agree, I can see why there might be certain circumstances where it would be more preferable to actually not do this. The indices are made from single measures, and many of the indices have overall scores as well as domain-specific scores. For example, the Environmental Justice Index has environmental domains, social vulnerability, and health vulnerability. And then within those domains, there are also subdomains. I do want to point out right now that the Social Vulnerability Index is this thing that the EJI uses to measure social vulnerability. So while there are sub-themes within this domain, the sub-themes for social vulnerability and EJI are just the sub-themes for the SVI. So it's socioeconomic status, household characteristics, race and ethnic minority status, housing type, and transportation. Structural Racism Effect Index has 9 different domains, including criminal justice exposure. And while the Area Deprivation Index provided by the University of Wisconsin doesn't have sub-themes or domains, the ADI-3 created by Berg et al. Does include 3 different domains. And the reason that Berg did this is because they found that the ADI failed standard tests of construct validity, leading to have these other 3 measures. And this was the big table I warned you guys all about. So what is actually in these measures, and the reason behind creating this giant table you see here is that a lot of the indices have overlapping measures. And like I said, this was the big table I was going to show you. Also, just to warn you, this is just a snippet of the table. The table is actually twice the size. Many area level measures, especially those that focus on housing and socioeconomic status, are derived from the American Community Survey, or the ACS, that I'll go over in a little bit more detail in just a moment. As you can see here, all of the indices I looked at least on this part of the table, have high school graduation. They get this from the American Community Survey. They also all have poverty in it, though the definitions vary a little bit. It's just not on this part of the table. Some of the measures were developed to address certain structural inequalities, such as the Structural Racism Effect Index, or to address the concerns of certain populations. For example, the Child Opportunity Index was developed for children. Using them interchangeably removes what they were validated against, which is also, by the way, speaking of validating, the PCA is going to use whatever measures that you put in it. Factor analysis that I mentioned earlier capitalizes on what covaries together and not what matters mechanistically. Do want to give a caution about using the Area Deprivation Index, though I think actually you all already know this, but I think it's worth mentioning. The ADI, or the Area Deprivation Index, uses unstandardized values. Thus, variables with money in them or large ranges get a lot more weight than variables that have less of a range, like a percentage. For example, around 98% of the variation in the ADI measure can be explained by just 2 measures, income and housing value. So while the ADI says that it's a multidimensional measure, it is largely really only relying on 2 measures. Standardizing changes a lot, and over on the right, I have an example of it from Peterson 2023. This is for DC. Without standardizing, you can see that largely this measure is really capitalizing on home values and home income. Once we standardize, we actually see a lot more variation within DC. This is especially important to urban areas. Without standardizing, urban areas tend to consistently have way lower deprivation than one would think if you'd ever been in any of the areas. And why does this happen is that you have much higher home values in urban areas. Research has suggested using area-specific scores, meaning your PCA and rankings are determined by your analytic sample. The ADI was developed to be used at the Census block group, and I just want to warn you, if you do recreate your ADI measure yourself, you use standardized values, etc. and you want to use it at the block group level, I will warn you that these tend to be unstable. I have a heck of a time getting it to work. And while Peterson gives pretty great details about what they did to overcome this, including imputations, the ADI people do not. In general, I just honestly estimated at the census tract level rather than the block group level, because for me, it didn't really seem worth it to get down to the block group level. Some questions you can ask yourself when you are considering whether to do it is how much of your how much geography does your sample cover? If it's just Jefferson County, it might be worthwhile to get it down to the block group. Additionally, you can think about how clustered are people within the geography that they are coming from. This can help you answer the question about whether it is worth it, but not if the estimates obtained are meaningful. The American Community Survey, that I've mentioned a couple of times, is integral for these indices. The ACS replaced the decennial census long form after 2000. The decennial census had two forms, a long form and a short form. Short form was basic demographic information and is obtained for each person in the US. And the long form was distributed to approximately 1 in 6 households. And this is where that rich socioeconomic indicators come from. The ACS was developed largely because it seemed important to have estimates of the population in the interim between each decennial census. And so how does the ACS do this? Is it collects information on a rolling basis. Thus, it is always going on. And in order to get estimates at the area level, we aggregate across many different months. So if you get a 1-year estimate, that means they aggregated across 12 months. And if you get a 5-year estimate, it means that they aggregated it across 16 months of data. And for SDOH research, you're likely going to want to look at the 5-year estimates. 1-year estimates can be used for bigger geographies, but 5-year estimates you can use at the census tract or the block group. And now I just kind of wanted to put the persistent poverty initiative, or specifically the definition of persistent poverty into context. The persistent poverty definition used by NCI means a place is in persistent poverty if it was a high poverty area in the 1990 decennial census, 2000 decennial census, the 2007-2011 ACS, and the 2015 to 2019 ACS. I do want to point out that this covers 3 different census geographies. Remember, they change every 3 years. And the NCI used the IPMS NGHS file to harmonize the different boundaries. I also want to point out that the NCI definition differs a little bit from the census definition. The census uses a different definition rather than using the 2007 to 2011 ACS, it uses the 2005 to 2009 ACS. Using one versus the other will give you slightly different definitions. And to visualize this, I created an even different definition of poverty using the 2009, 2013, and 2018 ACS, and then mapped it. So the tracts in blue are persistent poverty tracts according to the NCI definition, and the ones in red are the ones that I pick up on using my definition that were not identified as PP, as persistent poverty by the NCI. Now, before I go too far into this, I do want to point out that I have one problematic year since 2009 is in both the 2009 and 2013 estimates. So how you define things matters, and definitions are choices. Using one definition over another means you will gain some individuals and lose others. Rather than thinking of this as a nuisance, it's honestly a chance for research. And what your research question is important for figuring out which definition you should really use. If your goal is to identify why areas are doing better or worse than other areas, or is your goal to recruit from areas that have worse exposures or outcomes? If you wanted to recruit and you were using the definition that came from NCI, you would miss any of the red census tracts that I've pointed out here. And in order to give that a little bit more context, I'm going to compare 2 census tracts in particular, And these are the ones associated with those big black arrows. So we have our not PP census tract and our PP census tract. Why did I pick these two? Is because they're right next to each other. So what do these two areas look like in terms of sociodemographic characteristics? So this is pulled from the 2018 ACS. And on the left, I have the PP tracts and the non-PP tract of those two census tracts that I just pointed out on that previous slide. And they look pretty similar, though I will say that the PP tract is younger, less white, and has higher poverty rates. But interestingly, the not PP tract has slightly lower education levels and actually way higher levels of unemployment than the PP tract. And then the table on the right is just comparing tracts in Alabama by the two different definitions that I used. And while the two different definitions look pretty similar across the different categorizations, those that are in both tend to have the highest values on the measures associated with disadvantage. Also, you're going to lose people. So if you use my definition, you lose about 30% of the PP tracts. If you use the NCI's definition, you lose about 30% of the tracts that I identified. So this is just important, once again, for thinking about how your choices, how you define things, matter for the interpretation of your findings. So all this to say that your theoretical framework should guide your choice of measurement. When you are thinking about SDOH research, think through why this measure would matter for the outcome you are looking at. If you think education is important for adherence because it increases health literacy, then you should likely also measure health literacy. If you find that insurance is important for getting a referral, it is probably less about insurance and more about access to medical care. These pathways interact and reinforce one another. And then specifically what I'm going to show you now in this last part here is about how neighborhood and individual SES influence one another and how this can then is influenced by cancer. Which I said brings me to the third part, which is the real world example. So does cancer diagnosis impact home sales and how? So I'm going to walk you through my research question, how I managed to harmonize the data, the different data sources I used, and a little bit of some preliminary findings. And like I said, big warning, these are preliminary findings. I'm still working out the kinks, but I would be very interested to hear what y'all think. And so what I was really interested in here was turning the question on its head a little bit and thinking of persistent poverty as both a cause and potentially a consequence of cancer. And to do this, I started with thinking through my conceptual framework, where structural conditions result in concentrated poverty. Because of this, wealth is concentrated in home ownerships as there are few alternatives. Then you get a shock like a cancer diagnosis, which in and of itself is expensive, but you can also have other expenses that come about from it, such as lost work. This could lead to an accelerated or below market home sale. And then why? Because households liquidate their largest source of wealth to cover the proximal costs. Wealth is then extracted from the community, and in Alabama and in the South in general, these purchases go to institutional buyers more and more often. So my claim is not that persistent poverty causes cancer, but rather persistent poverty organizes the structural conditions through which a cancer diagnosis becomes a wealth shock, a housing loss, and a transfer of disadvantage. So my project, in collaboration with Dr. Husseini, had 4 questions, and 3 of them I'll actually show you results for, the 4th one coming soon. So what aspects of cancer lead to accelerated home sales? Do those with cancer sell their homes below market value compared to those without cancer? And what aspects of cancer lead to a distressed home sale? And finally, like I said, I'm not actually going to show you this, but I think it's important. Does neighborhood context, meaning socioeconomic status or persistent poverty, influence these relationships? In order to do this, I need to connect cancer patients to households to communities. I need data at the individual level concerning cancer and address. I need household level data concerning value, sale date, sale price, and assessed market value of the home. And I need tract level information concerning community characteristics. And once I have these data, I need to figure out how to pull it all together. And the graphic on the right here lists the data sources that I use. So at the individual level, I get information on cancer patients from the UAB Cancer Registry, information about household sales or sale prices from Cotality, which was formerly called CoreLogic, and then information about the census tract comes from the ACS or Decennial census. But before I go over that, I want to discuss what the limitations of this data that I have are and what this means for my interpretations, or if there are alternatives or sensitivity analysis that will allow me to understand how big of an issue this likely is. When you're using real-world data, this is a really important thing to think through. These data tend to have quote unquote issues associated with them, but you can likely overcome them by sort of thinking through what this means for the interpretation of your results. The first limitation is that this is a single center study. I'm getting all of my cancer information from UAB. However, I make the argument that because UAB is a tertiary medical center, this means we will likely see all incidences of cancer, maybe for like a second or third opinion, but we may only see them once. So we will likely have a decent match between the incidences of cancer and homes in Alabama. We will reduce the number of hopefully reduce the number of cancer sales that are identified as non-cancer sales. However, this limits our ability to see how cancer treatment influences the relationship. If they don't get their treatment at UAB, I can't see how treatment then led to accelerated or below market home sales. A second issue I might have is we might have misalignment between the parcel or house and the cancer patient, meaning does the individual cancer actually own the home? In order to limit the likelihood that this was an issue, I limited my Cotality data, where I get my housing information from, to just houses that claimed a homestead exemption. A homestead exemption is a tax designation, which means you get to pay lower property taxes if you say that your primary residence is this residence. So that was my attempt to try and make sure that people are actually living in the homes that I've identified. The cancer patient could still be a child, spouse, or roommate of the householder. However, I would argue that cancer is likely a household level disruption and not just an individual level disruption. So me personally, I'm okay with this ambiguity. I can also have issues with timing. Timing of obtaining the addresses from the cancer patient, also timing of the sale of the home. The address on file may no longer match the cancer patient's address, especially if this person just came here for a second or third opinion, and they could have moved before the last sale. So whoever last sold the home was the person the cancer patient sold the home to, and not the person that is currently, not the cancer patient. So the Cotality would have whoever they sold it to. So as a sensitivity analysis, I suggest limiting it to those whose last encounter was within a year of their home sale, increasing the likelihood that they still lived there and that the addresses that we had on file from the cancer registry was a correct address. And then this is just an issue that unfortunately I have to just settle with, is my lack of rural representation. And this is actually an issue across all three of the different data sets that I've pulled together. The figure I have on the right over here are all the homesteaded addresses in Cotality for Alabama that also have information about sale date, sale price, average market, or assessed market value. And as you can see, I have holes. Some of the holes make sense, as a big swath of this over here is like the Sipsey wilderness. People don't live there. But some of the holes are obviously where people live. And if you zoom into some of these holes, you notice that they match up pretty nicely with county boundaries. So why is this the case is that more rural counties are less likely to have digitized records, meaning that they're just not going to show up in totality. And that's leading to my coverage holes that you see here. Like I said, I also have issues in the other two data sets potentially as well. In the ACS, census or rural areas have smaller populations, so errors tend to get bigger. Well, that's kind of true. What really tends to happen is that rural census tracts are much larger geographically than urban tracts. Also, non-response to the ACS or census is higher in rural areas. And concerning the UAB cancer registry, people who live in rural areas are more likely to have mailing addresses that are postal boxes, and those will not geocode. And even if they did geocode, it doesn't matter because nobody lives at the post office. So now let's actually discuss the data. So the cancer registry has over 47,000 cancer diagnoses between 2019 and 2024. Some of these people are in there more than once because people can have cancer more than once. So I limited it to a single observation per person, and then I geocoded. Most of the address is geocoded. For totality, I had about 600,000 homesteaded properties, and about 150,000 of those sold between 2019 and 2024. The ACS data, which I will totally eventually incorporate in this project eventually, is coming soon. Remember, these are preliminary. But what I need from the ACS or the census is that census tract information. And before I show you the results, I wanted to really take a moment to discuss the sort of steps that I went through to match the cancer registry to the totality data. For the cancer patients, I needed to geocode them, which just means turning their addresses into XY coordinates. And importantly, I need to do this in a HIPAA compliant way. In order to make sure that I did this in a HIPAA compliant way, I used ArcGIS and StreetMap Premium, which means my addresses are never sent to a cloud or a third party. You can get other programs to do this. I know that R has some built-in codes that you can use that you can put in an address and it'll give you back the census tract. However, you are no longer doing this in a HIPAA compliant way as this it puts information out to the cloud. For totality, I did have XY coordinates of the parcel, but not from totality itself. But not surprisingly, these lined up horribly with my cancer data because it was the XY coordinates of the parcel and not actually necessarily the home. So my solution for this was to geocode the in situ address that came from totality of the primary building on the parcel using the same method that I geocoded the cancer patient, so using StreetMap Premium. And I did this so that it means I'm using the same reference populations. So the XY coordinates will line up perfectly. They'll intersect at a point, not just an area. So what does the match data look like? I was able to connect a little over 11,000 cancer patients to homesteaded totality parcels in Alabama. And of these, 1,179 sold their homes after a cancer diagnosis. And about 11% of these were a distressed sale. As you may have noticed, I have a lot more cancer patients than I was able to connect to totality. I likely did a better job of identifying cancer patients to totality than totality to cancer patients, which means my estimates are likely conservative and that there are likely to be more non-cancer sales that are actually cancer, that sales that identified as cancer that are actually non-cancer. And all of my decisions along the way tried to accomplish this. This also really only impacts my second question, which is, do those with cancer sell their homes below market value compared to our non-cancer sales? Concerning my lack of real representation, the error is probably on both sides, both on the totality and on the cancer side. as well as in the, meaning that it's both on the sale and non-sale side. So it's a limitation, but it doesn't necessarily invalidate my results. It's just important for understanding and interpreting the results. So what are my preliminary findings? Concerning my first question, do those with cancer or what aspects of cancer lead to accelerated home sale? I found that those with colorectal cancer and those with later stage at diagnosis have higher hazards of home sales. In order to look at this, I used Cox proportional hazard models to look at time to home sale after diagnosis. And I also give you the unadjusted and adjusted hazard ratios here. The adjusted includes covariates for age at diagnosis, stage, race, ethnicity, sex, and marital status. Importantly to note that this sample, these are just my cancer patients. Concerning my second question, I found that those who sold their homes more quickly after a cancer diagnosis did so at a greater loss than those sales without cancer. For this, my sample is the 100,000 or the 1,000 or so cancer sales that happen and the 150,000 non-cancer sales. I use linear regression, and the outcome is the percentile that you in my sample that you either lost or profited from your sale. So the profit is calculated as the sale price minus the assessed market value. And I looked at cancer in two different ways. A dummy variable for has cancer or not, and then I further divided my cancer patients by time from diagnosis to home sale. Looking at just the cancer dummy variable, I find that cancer sales are actually more likely to sell at a higher value or more likely to make a profit compared to the non-cancer sales. Importantly, my reference group here are non-cancer sales. But this goes away after I include my covariates. My covariates in this example are year of sale, number of bathrooms, age of the house, square feet of the living space in the house, and square feet of land. And also county level fixed effects are included as well to help account for the fact that housing markets vary a lot over areas. So why do we see the cancer people tending to have more of a profit when they sell their home? Is it largely seems that cancer people are more likely to be older, and older people are more likely to own older homes and bigger homes, which is why once I've included my covariate, that relationship goes away. Breaking down cancer by how long after the diagnosis they sold, we find that those who sold quickly after a cancer diagnosis were more likely to sell at a loss compared to non-cancer home sales. Those who sold 2.5 years after a diagnosis sold at more of a profit or had less loss than those with non-cancer sales. The last two groups over here were largely what was driving that relationship when I just had cancer as a dummy variable. Adjusting for covariates, I still find that those who sold quickly after a cancer diagnosis within the first 6 months sold at more of a loss than our non-cancer sales. And for my last question, I was interested in what predicts a distressed sale among cancer patients who sold their home. So for this, I used logistic regression, predicting distressed home sales amongst all of my cancer patients who sold. And I give you unadjusted and adjusted odds. Adjusted odds include covariates for stage, race, ethnicity, sex, cancer site, age at diagnosis, and marital status. And I find that compared to those who sold quickly after a cancer, those who sold more than 4 years after their cancer diagnosis have about half the odds of having a distressed home sale compared to those who sold within 6 months of their cancer diagnosis. So in summary, what does this all mean? Your choice of geography influences what you can see and measure. And whenever zip code, census tracts, what to do if you just have zip codes. Also, definitions should be based on theory or your conceptual model. And while this is really nice, and we all always say this, data limitations are real. What you can do plays a big role on what you can look at. understanding how this influences what you can ask and what you can find out is important. Which is what I was trying to do when I discussed all of my limitations with my data. Like, yes, there are limitations, but I think that there's results we can find are still important and they can be overcome. And then finally, individuals have multiple levels of influence, and these influence and interact with each other in ways that are meaningful for research. And that was the end of my talk. So I'm happy to take any questions y'all might have. I'm going to go ahead and stop sharing so that I can see everyone.
Great, thank you, Liz. If anyone has questions, please feel free to unmute or put it in the chat and I will take it from there. Maria?
Hey, Liz, thank you so much for this talk. I especially appreciated your going through the limitations of this before even starting, because I mean, you're right, there's a lot to consider, a lot to really understand before you even jump to looking at the data and interpreting what you're finding. So I have a few questions about okay, a few method questions, I guess. One is, so the census tract, I noticed you said census tract goes from 3,000 to 8,000 people, but how do they, or something like that, I can't remember. So how are they really, I mean, what makes them 3,000 versus 4,000?
So the idea is to try and get like areas that represent theoretically like a neighborhood. So they won't do things like cross like interstates or stuff like that, right? Because the moment you cross an interstate, those aren't really connected anymore. And then the goal is really to have about 4,000 people in that track so you produce stable estimates. So there is some thought about like, do these people even belong together? Like, would you expect them to hang out? As well as do we have enough people in there to say meaningful things?
I see. Okay. And then I wanted to ask you about you talking about the different persistent poverty, you know, how that can change the persistent poverty. But then, so how do you choose one versus the other? Like, why would you choose yours versus the other? I mean, what really?
Okay, so I will admit mine was wrong, and that was
No,
largely
no,
because I
but
didn't want to deal with the fact that we have changing geographies if I expanded it out anymore.
but I mean in general, right? So when you have whatever it is, it's wrong or right, whatever. Well, it seems like a discussion about congressional districts, right? How do you really define them? How do you choose the definition?
But like honestly, my favorite way to handle this is to look at it all of the different ways, and by sort of comparing and contrasting the different ways that we define something can give us a lot more insight into what these definitions mean for our outcomes. So similar to my colleague that I made zip code level measures for, I gave them both the ZICTA derived measures as well as the tract weighted zip code level measures. They should behave relatively the same, but they might not.
Right.
It'd be important to know how they do or do not sort of converge or diverge. And if like my favorite thing is like if we do choose from the multitude of different ways that we could define persistent poverty, if you're largely getting the same answer again and again, then that means that, you know, we've done a pretty good job on it. And you can use any of them.
Thank you.
Liz, I have a question about so you went about your limitations and things that you could do and how you thought about being able to interpret your results. So my question is, what are you thinking? And of course, this is work in progress. So what are you thinking as your next steps to continue your research?
So with this project in particular, or like expanding beyond this project?
Both.
Okay. Are y'all familiar with the concept of heirs property? Heirs property is when you have a tangled title And it means it's really difficult to determine who is the actual owner of a house. And this is far more likely to happen in areas of underinvestment. And so the totality data that I use, I got from a colleague, and he has staked his claim to fame on being able to identify heirs property from that totality data set. And I'd be very, very interested to know how being an heir's property influences your health outcomes versus not being in an heir's property. If you die and you have an heir's property, it can be difficult to figure out who gets it. Institutional buyers can come in and kind of swoop up and take it.
Mhm.
Also, people can sell your home from you while you are currently living in it because you do not actually have the title or the deed to that house. So I'm very, very interested in connecting this beyond just sort of, do people sell at a loss, to like, how would aspects of the house and the housing characteristics that you have influence your health outcomes?
That would be great.
And also heirs property is really hot right now. So if you go around looking for it, you'll probably find it somewhere.
Another question that I was thinking about is, did you find, and I saw you listed all the types of cancer that you considered. And thinking about the type of cancer, did you find any difference between cancers and more aggressive cancers? Was there any difference?
So the only thing that I really have to kind of piece that out right now is stage. And unfortunately, stage is collected like pretty terribly. There's a lot of missingness in stage. So I'm not like the most excited about that. But I actually didn't like look at it by different types of cancer, which I think would be really cool now that you mention it. So like pancreatic cancer tends to not have a very high survival rate, whereas things like breast cancer might have a higher survival rate, or skin cancer actually definitely has a higher survival rate. So I think that it actually, that would be a really good way to kind of like piece that out a little bit, is by looking at the cancer site.
Yes, I think that will influence how people respond to the, selling or not selling. Thank you. It was very good. I enjoyed your talk.
Victor, go ahead.
Yes, thank you so much. Sorry, I'm not in camera right now. So I'm thinking about a project that is proposing to compare urban versus rural populations, and that's usually a lot, right? We try to attend that. So I was thinking, well, I wanted to ask you, what is your recommendation, right? When we really want to do that, is it really census tracking? We really classify census tract as rural, as urban? Is that the best way? I know it's pretty generic, my question, but what would be your point for me to start?
Question.
Thank you.
Because how do you even figure out if a place is urban or rural? A lot of it relies on the RUCA or RUC codes. The Federal Office for Rural Health Policy actually has a 0-1 definition that they put out at the census tract level, which is my favorite definition personally. It uses the RUCA codes as well as some other information like how rugged the roads are, how sparsely populated neighboring areas are. The Federal Office for Rural Health Policy has a list of all census tracts that it considers as rural. And that is my favorite definition. As far as the fact that ACS just gets less response in rural places, there's not a whole bunch that you can do about that except acknowledge it as a limitation. And if you look at any of the area level measures, I would strongly suggest you don't use the area deprivation index, because urban areas are just going to look way better than they actually are. You can also use the ADI3, which does standardize, so you don't have that issue anymore. But yeah, if you want to know what my favorite definition of rural is, it's the Federal Office for Rural Health Policy.
Got it. Thank you so much.
Leslie, did you have a question?
Oh, I had a question about the housing data source that you used. How is that? I haven't heard of it before. How is that information? How did they collect that information and create that data set?
Yeah, so it's called Cotality. It used to be called Core Logic, and I think before that it was called Property Basic or something. It's a real estate data set. That's what it was created for. That's who largely purchases it. It's a very expensive data set. So my friend that does heirs property was nice enough to let me look at his data. But yeah, it's collected for real estate purposes. And it's based off of records that you sort of put in at your county or at your city.
That was
right?
my question. So it's based on the county records. Okay.
And mortgage information. It actually draws it from several different sources. So
Oh,
it's
that's
not
great.
just one thing. Yeah. And I know this sounds terrible, but I'm just going to say it. We live in a capitalist society. This data set's very expensive. So part of me thinks that like it probably does a pretty good job on it. There are other data sets that are put out by other real estate people, but
Well, I'm glad you were able to get access to it. This is great.
All right. Any other questions? Thank you so much, Dr. Baker, for your time. That was an excellent presentation. And thank you all for attending today and for your questions.
thanks for having me, you guys.
Thank you. Great presentation.
Yeah.